I'm doing it now. 15 minutes after the oxygen is replaced, he's rested, he denies he's being short of breath, you obtain an oxygen saturation, which is 96%. What do you think's next? What are you gonna do next?
D.
What letter?
D as in dog.
Oh, yes, that's correct. Because that's acceptable, right? That's an acceptable saturation. Continue to assess. You don't just go, okay, I'm done with this guy. No, you're going to go back and assess him again. But at this point in the game, that's an acceptable saturation. He sounds significantly activity intolerant, does he? He just went to the bathroom and back. Okay, so think about that, you know, that dyspnea at rest versus dyspnea on exertion. So he's definitely not one of those stage oneers, right? Or A or whatever you want to call it. He's further along down the line. So definitely reassess him, make sure he's doing okay. I can't tell you how many times I've had to replace someone's oxygen. Okay, after you assess them, you document the following. Jugular venous distension, 2+ edema in the feet and ankles, swollen fingers and hands, distended abdomen, bibasilar crackles on auscultation, and productive cough with pink sputum. Woo, there's a lot there. What are you guys thinking?
Right-sided.
Biventricular failure, I think.
Biventricular.
There you go, right? Because let's break this down, my friends. Let's break this down. JVD, the edema, the hands, and the belly are all right-sided. Okay? Those crackles and productive cough with pink tinged sputum, remember that's a warning sign for pulmonary edema. Those are left-sided. And remember what I said, left-sided heart failures eventually can show right-sided heart failure, right? It could just eventually back up. So this patient has both ventricles that are failing. So it's really important that you pay attention to those assessment findings because again, I said, remember if I came in and I had a heart attack in my left ventricle, I'm clearly going to show left ventricular failure side, right? Left heart failure at that point in time because it's acute. 5 years down the road with me living with left ventricular heart failure, it's going to eventually back up. Do you guys see that? So it's important that you're able to differentiate between left-sided, right-sided, or whoops, both sides. Okay, so very good, very good. During the morning care, if they're short of breath, tachycardic, what's your interpretations of these findings and what would you do? Silence.
Is it from pulmonary edema?
Well, I mean, we don't know that for sure, Dawn. So it could be, but I'm short of breath during movement and activity. So what is your brain saying? What are you interpreting as that?
Activity intolerance.
There you go, Carly. That's right. Now she's talking about that collaborative problem. This patient has activity intolerance, right? Because he's saying, you know, during his morning care, now he's tired and he's getting tachycardic. He's not tolerant of moving. So what interventions would you begin at this time? What would you do for this?
Vital signs.
Okay, what else?
Oxygen.
Well, oxygen.
Rest.
Okay, but okay.
Stop
said
doing
rest?
the morning care.
Thank you, whoever just said that. Stop doing the morning care. Pace those activities. Set that patient down. And then I'd say, yes, Dawn, let's get a set of those vitals. Let's see how he recuperates. You know, let's get him stopping whatever he's doing, tying his shoes, getting dressed, whatever. Let's see how he does. How long does it take him to recover? You know, if you get a SAT on him during this activity and his saturation level is 82, and it takes 10 minutes to get back to that 96, that's a very intolerant patient. They should, with stopping activity, that saturation level should go up. So to take that long of a time, we need to do some more things. Somebody said, give him some rest, pace those activities. Educate him about, hey, you can't do 15 things at once. Let's do one, take a rest period. Let's continue on to the next, okay? So really think about all those interventions that maybe you did for an activity intolerance nursing diagnosis care plan a while back. Yes, Dawn is right. Let's get a set of vital signs, see what he does. We already know he's tachycardic, but let's really see what that blood pressure is doing and what that respiratory rate's doing. So all of those interventions that you've done in the past really can play a part right here, right now with activity intolerance. Okay, during the evening shift, they have an echo. Remember I said I love echoes, non-invasive. Uh-oh, what do you guys think of that 30%?
It's bad.
Okay, Audra, fair enough. It's bad. Which should it be?
Over
60, over 60.
Yeah, 60, 65, 55, depending on who you talk to. Okay, so we all know this is significant. And if you remember, I was talking back when sometimes people's EFs are less than 35%, we start adding all kinds of stuff to it. So what medications, based on this finding, not just this patient that you picked up off the street that's on a bunch of medications, connect these meds to that ejection fraction. So which ones do you want to give? Anybody?
Dig.
Dig.
Okay, let's start with the DIG. So we're going to circle DIG. That's right, because what does DIG do? And if you haven't figured out, I'm reviewing with you guys. So like,
Contractility, so it gives that good squeeze.
okay, so that's that positive inotrope. Really helps that heart squeeze more effective to help with that cardiac output. So it's a positive inotrope, right? But what I said, it was a negative what? What does it do to my rate?
Decreases
Decreases.
your heart rate.
Okay, so what do we need to do as safe nurses to give this med?
Check your
BPN,
pulse.
heart rate.
Heart rate doesn't affect the blood pressure as much. Digoxin, heart rate for sure, 100%. How do I know that I am at a therapeutic level?
Your dig tox,
They-
your dig level.
So
your
what
blood
should it
work.
be? What should it be?
0.8 to 2, right?
Exactly. So your brain says, oh, patient's on DIG. Did anybody ever get a DIG level? Oh, they didn't? How do I know that somebody's DIG toxic? Without even getting a level. I mean, all right, you're all gonna come
Halo.
back.
Oh, sorry.
You're all gonna come back and say the level is gonna be high. But how do I know someone's DIG toxic by their, I know that, that's obvious. We don't have a level yet. So how do I know they're DIG toxic?
Tremors, shaking,
Nausea, vomiting, diarrhea.
sweating.
Whoever said nausea and vomiting, I want to just stop there for a minute. That's the only one I'm allowing you to put on your med card, because that is a classic sign of DIG toxicity. Patients are vomiting, they're really nauseated. Good. What else?
Confusion.
Could be if my heart rate is what?
Low.
Yes. So they'll come in. I've had patients come in and their heart rate's 30, and you're like, ooh, what happened here? So definitely, I think it was Audra said it, confusion is really probably a cardiac output issue, because now I'm not even pumping 60 times a minute. Now I'm 30. So I just gave you another one. Bradycardia. Really look for those signs and symptoms of DIG toxicity. That's going to alert you. Hey, everybody, let's pause and let's get a level and let's wait to give this medication. Let's say you go in and you don't have the level back. And what are you going to do first? You're going to get a
Heart rate.
yes. And your heart rate is 50. What are you going to do?
Hold it.
Hold the med. Call the provider.
Absolutely. Thank you, Brianna, for bringing that second connection to it. Not only do you hold meds, nothing ticks off physicians, providers more, is you've been holding a med for days and no one told them. So he thinks he's getting the DIG. So you hold the medication and notify the provider. Absolutely. Excellent job on the digoxin. So remember, they can become toxic quite easily because there's a narrow therapeutic index. You just told me 0.8 to 2. Very small. Very small. So we do want to get a level. We do want to see what's going on. What do we worry about? What type of patients can become more toxic more quickly?
Chronic kidney disease.
Yes. Yes, Nancy. We can't excrete that excess, so those levels will build up. So you might see somebody with chronic kidney disease on a Monday, Wednesday, Friday dose and not every day. So somebody with chronic kidney disease, what electrolyte if it's not normal?
Potassium.
Potassium.
Low potassium, right? So your brain says, it says brain, before I give digoxin, I'm going to check the potassium level. I'm going to check the BUN, creatinine, GFR. All that in the chart. Then I'm gonna come and I'm gonna check that patient. I'm gonna make sure that patient's heart rate's greater than 60. And I might even ask, how you feeling today? Oh my God, I'm so nauseated. I think I'm gonna throw up. Okay, and I'm seeing what kind of vision. What did I say about the vision?
Like the halos, the lights, the
You'll see like
yellowish.
colored vision and like purple or yellow, or I've heard more yellow, green, not purple, but your book says purple, halo kind of lights and change in that vision. So really ask your patient, because you sometimes don't have time to wait for a dig level. You know what I mean? You got to get it, draw it, send it down. You don't want to give them that day's dose if they are really manifesting signs and symptoms of toxicity. Excellent job on digoxin. Okay, so I like C. What else you giving me?
Would you give the lisinopril?
Heck yeah, because what did I say about ACE inhibitors for heart failure?
First line,
Say it again. Number one, somebody said. What else?
Decreases preload.
Thank you. And it decreases what else too?
Afterload.
It does both, doesn't it, you guys? So now we're talking about these two concepts of preload, of that excess volume dumping back into the heart. It's going to decrease that. And then it's going to decrease the amount of resistance the heart has to push against to get that blood out. Gold standard, first line treatment. Only reason I wouldn't take this lisinopril is what?
the coughing spell.
Not gonna take it. It'd probably be annoying. It's not a contraindication. It's probably the number one reason why people stop taking it, Brianna. But it's not a contraindication.
Angioedema.
Hello, somebody, I think it was Brianna mentioned the other day too. The angioedema. If you had a prior history of taking an ACE inhibitor and your face swelled up, oh my God, total absolute contraindication. The cough is annoying and the patient may stop taking it because of the cough, but you really need to educate them, say, whoa, pump the brakes. You need to call the provider and tell them that this is bothering you. What can we do about it? What's a better choice then?
Arbs. Arb.
I like it, ARBs. So like a sartan, right? So anything candesartan, valsartan, a sartan, because of the less of the cough. What's the side effect with the ACE inhibitor and some of the ARBs that I worry about? Remember, I come from a renal world.
Rhabdo.
Rhabdocystatins.
Hi, Kay.
Hyperkalemia.
Hi, Kay, thank you. So you start them on this ACE and you're like, what the heck happened to my patient's potassium level? Start to suspect the ACE inhibitor, okay? Start to suspect the ACE inhibitor as the culprit. Now, don't get me wrong, it could be something else, but that's definitely an issue. And look at your BUN and creatinine GFR with that. Excellent. So ACE inhibitor, gold standard, decreases preload, decreases afterload. Excellent choice. Give me one more. Oops, I just gave you.
Lasix E.
Okay, so Brianna says Lasix. What kind of drug is Lasix?
Loop diuretic.
Okay, excellent. So we have a loop diuretic. What are we worried about?
Your K.
What happens to it?
It decreases.
Yes, definitely decreases. So definitely paying attention to what that potassium level is while I'm on the loop diuretic. Okay, definitely. In particular, and I kind of talked a little bit about this, if they're like an acute pulmonary edema and we're giving IV, it's definitely going to drop their potassium much quicker as well. So pay attention to that. You'll see next semester in the ICU, you will be giving a ton of loop diuretics IV. Nice and quick, they respond quickly. We don't have time for a pill to work. So you will be giving those quite frequently. Bumex is another one. What does the diuretic do? Where's Tori? Tori!
Decreases your preload.
There you go. Decreases the preload. We're getting rid of that excess volume. So we're decreasing that preload. Okay. Now, students ask me all the time, can they be on all three of these? What do you guys think?
Yes.
Yes.
100%. One is not better than the other. You never have to choose, ooh, do I give an ACE over a loop? That's not your decision. Your decision is to give it safely and look it up and know how to administer it safely. Okay. Any questions on those meds while we're here? Excellent. Let's flip. which of the following symptoms would the nurse anticipate with right side? So when you're taking test questions, you guys really say that to yourself 3 times. Oh, she's asking me about the right side. She's asking me about the right side, not the left, the right side. So tell me what symptoms you want or you will see in somebody with right-sided heart failure.
It would definitely be the neck vein distension.
Right? Because things are backing up. Okay, that's fair. Go ahead.
And the,
Large
and D,
abdomen.
then large, yeah, the large abdomen.
Okay, let's talk about that. So it's not that it gained weight per se and got excess.
Ascites.
You got it. That's 100% right. So now this patient has excess fluid in their abdomen, ascites. So they might say, oh my God, my pants are so tight. Oh, maybe I can blame that why I can't zip my pants today. I have ascites. Maybe I'm in heart failure. I don't know. So it could be all the sugar I've been eating. But anyways, point being, it's not that they've gained weight or fat per se, it's excess fluid volume. And they go, oh my gosh, my shoes are tight, my socks are tight, I can't button my pants, excess fluid. What else would you see in right-sided heart failure?
I think that S3 sound, right? No? Hmm.
Now, I would probably more often see the S3 in left-sided. However, all right, let's just pause a minute. You could be right. Maybe we hear an S3 on the right ventricle or something like that, because if the ventricle is non-compliant or overstretched, you could definitely hear that. I wouldn't go to that right away. I usually think of left-sided first, but I'm going to have to say I don't disagree with you on that. It's
Okay.
possible. It's possible. What else?
Someone already say that.
Wait, Dawn, hang on 1 second, then I'll go to the next one. Dawn?
Did someone already say like the club fingers and the edema?
So let's break those down for a minute and let's talk about club fingers and the edema. Yes. So that 3+ pitting edema in your ankles, back to those tight shoes. That's exactly right. Pitting edema in your lower legs. Very important when you guys are assessing pitting edema in your patients that you physically touch the patient. Because I'll watch a physician, a provider, lift up the blanket and go, oh no, edema. And I'm like, touch their leg. And there's an indentation. Even though their legs may look thin, they're still pitting edema. You have got to touch for the edema. So yes, Dawn, you're 100% correct. The clubbing, I think where you're going with this, Dawn, is somebody with significant COPD who's chronically hypoxic are going to get clubbing. Yes. If it's a chronic situation, she's absolutely right, because they've been hypoxic and they've had right-sided heart failure. I can have clubbing and not have heart failure too, though. Just remember that, like young children who are chronically hypoxic for whatever reason can get clubbing. So the clubbing occurs because of chronic hypoxia. But yes, the connection to COPD and significant lung disease will definitely cause clubbing. Anything else?
Shortness of breath. Did we say that one?
Shortness of breath, probably more often on the left, because we're going with those pulmonary system. Now, can I say that they're short of breath because they have 15 pounds of excess weight on? And let me tell you, what's that?
I said, that's what I was thinking because of the edema. I thought that would make them become short.
Not always.
Okay.
I don't connect the shortness of breath with the truly, and again, the truly only right-sided heart failure. Certainly it could be a challenge to go upstairs or have activity intolerance because of that excess fluid carrying around. I wouldn't pick that as right-sided heart failure specifically. It'd probably be biventricular or left-sided heart failure.
Dr. Colmer, I have a question on that. I was
Yeah.
watching one of the videos earlier, and it said on right-sided heart failure that it could be shorter breath and increased respirations due to not enough blood flow to the lungs to be oxygenated because it was
So-
all backing up.
So yeah, if you're talking like a PE, see now with COPD, you're getting blood to the lungs. You are getting blood to the lungs. There's just a lot of pressure in there. Something where we have a massive PE that's blocking the blood flow totally, 100%. So yes, you can have, I mean, if it's a PE, which is a major cause of right-sided heart failure, they're gonna have chest pain, shortness of breath, definitely, because there's absolutely no blood flow. Make sense? Did it help?
Yep.
Okay, okay.
How about hepatomegaly?
Absolutely, because things are backing up. Remember that the venous system is a capacitance vessel, so that it just keeps stretching. It can back up and cause that liver to be enlarged. Absolutely.
So just to clarify on this question, what are the right answers? Because we've talked about a lot.
Neck vein distension and a large abdominal girth.
Thank you.
So the shortness of breath, what Trisha was saying is definitely plausible. It's definitely, so that leads me to say, I ain't putting that as an answer because y'all will pick it and then you'll fight with me and then we ain't going down that rabbit hole. So definitely with a PE or whatever, you know, if we're looking at those classic symptoms, I always think of pulmonary congestion, shortness of breath, left-sided, but you are right. If we have the significant pulmonary embolism that's blocking the blood flow and I'm severely hypoxic, absolutely. In any cases of hypoxia, I'm going to be tachypnic and short of breath. Everybody got that? Any cases of hypoxia, I'm going to be tachypnic and short of breath. So I'll make a mental note not to put that as an answer. Okay. Patient with chronic heart failure has been prescribed Corlinor. What assessment data would cause the nurse to question giving this medication? So Corlinor is something we give in the IVs, in the ICU via IV. Because what's the big side effect of Corlinor? Flip back, flip back.
Can you see the chat box, Lorraine?
I can't. Well, hang on.
Okay, because people are putting answers and I didn't know. Everyone's saying
Low
hypertension.
BP. Low BP. That's correct. Low BP. Yep. I'm sorry. Thank you. I hate
That's
to. If I open the chat box, can you guys see it on the screen or does it block the screen?
No.
Oh, good. Okay, then I'll leave it open. I thought it maybe blocked. So definitely low BP, because that's a side effect to the drug. Okay. So if you're already starting with a low BP, you're going to make this patient crash. All right. Nurse expects what outcome in a patient who's taking a beta blocker? So what do we want to happen with taking the beta blocker? This one might be hard.
B.
B, improved activity. Yep. Tolerance. Yep. Doesn't do contractility. That's an inotrope. Yep. B. Very good. That's it, isn't it? Yeah, it is. All right. So I'm going to stop sharing. Questions I can answer before I pull up our nurse Tim, because I think that'll help us go through some heart failure as well. Any burning questions?
Dr. Colmer, I do.
Okay.
I always do too. I'm like Carly.
You and Carly are twins. Go ahead. What's up, Nancy?
Okay, so if you walk into, let's say you walk into a room and your patient is having some issue, having heart failure.
How do I know they're having heart failure?
Well, I mean, they're having difficulty, let's say they're having difficulty breathing,
Okay.
and you walk in, and so is you're going to put them up in high Fowlers, make sure they're sitting up, or are we throwing oxygen on, or, I mean, I know that there's like.
So I guess what you're trying to ask me is how do you prioritize? So,
Yes.
So in any case scenario, if there's something you could do right away that can immediately improve somebody's breathing, hence putting the head of the bed up first, because you have that. Do you have a nasal cannula in the room, or do you have to walk out of the room, call respiratory, do all those things? But you don't go, hey, I'll leave you flat till I get you oxygen. So do you see how I would make that decision? I can immediately put them in high Fowlers to help that patient. Maybe that might be enough, probably not, but I'm going to put them up and I'm going to yell down for somebody to go get oxygen. Make sense?
Okay.
Now,
Yes.
in the question, if it theoretically back to the guy who had oxygen on and then went to the bathroom and came back, and they even say in the question, the oxygen sitting on the bedside table. Smart nurse goes, well, I'm popping that back on. He already has it ordered. Do you see what I'm saying?
Mhm.
So definitely you as the nurse, when you're thinking of that prioritization, what do I do to fix them to save their life right now? You know, you see somebody unconscious, you don't just go, I'm gonna walk out of the room and go tell a nurse. No, you're gonna start CPR, you know, that whole process and yell for help while you're attending to the patient. So always think about what you can do to help that patient right away.
Thank you.
You're welcome. Other questions? So you're experts in heart failure. I can only see Trisha's head going, no.
No.
I'll say no. Yeah, okay. No, okay. Nope, we're getting a no. Okay, it's okay. I think that you're getting a good grasp on the medications, which is a good thing because this whole bunch of medications is probably the number one prescribed. If you think about all your patients that you've taken care of, you've given diuretics, you've given ACE inhibitors, you've given these. So I definitely think you're getting a good grasp on those. Understanding the pharmacologic class, and that's why we asked you, tell me it's a loop versus a potassium sparing. They're very different. Don't just say, well, you know, it's a diuretic. Don't just say it's an antihypertensive. So telling me what pharmacologic class is really, because if you say it's an ACE, then my brain goes, I know exactly what to do for an ACE. Or if it's an ARB, I know what my brain exactly knows what to do with an ARB. So any other questions before I open up my Mr. Jones case?
Just a quick one, and it might be silly. I might have just over missed it when you were talking about it. But when we're talking about the coronary artery lesions, those are like the actual buildup of the plaque. That's all. Okay.
Yep. They use the term lesions.
Okay, because that's throwing myself off with.
No, they'll say, oh, they have a lesion in the coronary artery. Okay, so Bernie asked me when I have time, can I explain why pulmonary hypertension is right-sided? When I see pulmonary, I think left-sided. Okay. Again, this is that little picture that I said for you guys to draw. And let me see, I'm gonna draw you a picture right now. Because I am such an artist. This is how I study the heart. And don't judge or make fun. Can you see my big 4 chambers? Everybody see those?
Yes.
So I got a right atrium, I got a right ventricle, I got a left atrium and a left ventricle. Everybody with me? So this is how I study the heart, and this will really help you with hemodynamics next semester. What comes off of the right ventricle? Anybody know?
The pulmonary artery.
There you go. So I just drew it. I don't know if you guys saw it. So the pulmonary artery, everybody with me? We still there?
Yep.
Yeah. Okay. All right. So the pulmonary artery is the only artery that has deoxygenated blood. Right atria, right ventricle, whoop, through the pulmonary artery to the lungs. So that pulmonary artery is the only artery in the body that carries deoxygenated blood. And the pulmonary vein is the only vein in the body that carries oxygenated blood. So it's opposite of what you're thinking of, normal arteries and veins. So when we have essential pulmonary hypertension for whatever reason, the pulmonary hypertension from lung disease. So if lungs are damaged back here, it backs up into the pulmonary artery and causes pressure within the pulmonary artery. So have high pressure in that pulmonary artery, excess volume in that pulmonary artery. It's going to back up. You can't see my screen, to the right ventricle. So pressure, back up, build up, build up, build up, back into the right ventricle. So that's why it's right-sided heart failure. Bernie, did that answer the question?
Yeah, it makes sense now. Thank you.
Okay. Yeah, and see, I always have to draw that little symbolized heart because I'm not an artist and I just need to see it. I like to write and have visual. So thinking about, okay, I've got this pressure in this pulmonary artery, it's certainly going to back up and make that right ventricle stretch. And that's how I remember it, is thinking of the flow and how things come off of the heart that, oh, that makes sense. Pressure in that pulmonary artery backs up into the right right ventricle. Any other burning questions? You guys are quiet.
I don't have questions, but it's like, I don't even know where to begin to ask them. Like, I think I need to,
Well, start with something and then we can spin off of that.
all right, let me think. Give me a couple minutes. I'll come up. with
Okay, come back.
Here, I'll comment. That just super confused me, what you
What?
just said. Because I thought with left-sided heart failure comes with all the like pulmonary issues, like
It
shortness.
is. I'm not talking about crackles on the right-sided heart failure, Sarah Lynn. I'm talking about that pulmonary artery is distended and overloaded because of the lungs, not because of the left side of the heart. So when there's pressure in the pulmonary artery, things back up and the pulmonary artery is connected to the right ventricle.
Okay.
See my picture? Somebody
Maybe I
else-
didn't maybe I didn't hear her question right then. So she didn't
Oh,
ask about failure at all. She just asked about,
Well, she did. She said, I don't understand how pulmonary hypertension is right-sided.
okay.
It's because of how it backs up, because the
Okay.
pulmonary artery backs up into the right ventricle. Does that
I
help?
yeah, that I understand now.
Okay, good. And then July.
Same thing for the COPD then?
Say it again.
Same with the COPD?
Absolutely, because I have these damaged lungs that I can't perfuse. I've been smoking and they're rigid and pressure builds up. It's gonna back up, We're all one big long system, you guys. So if it can't go forward, it's gonna go backward. So if my lungs are not perfusing and exchanging appropriately, it's going to back up and there's going to be pressure in the pulmonary artery and then back up into the pulmonary or right ventricle. Okay, so think of that pressure building up, just like if you had a sink that you're trying to, run water and you have the plug in the sink, that water builds up, right? It's not going down the drain. That's how I think of it. That help?
So basically, yes, it does. Thank you. So basically, if you're having left-sided heart problems, it's because the deoxygenated blood has already made it to the lungs. And then something happens when it goes into the left ventricle that causes the problems from there. And that can cause a backup from left ventricle into the lung.
Yeah, because it's the flow. So back to let's go back to my very, very talented drawing. So if you look at, is this left? Yeah. Am I pointing to left? I can't tell. I'm reading backwards. So this is your left atria. This is your left ventricle. Let's say I have this massive MI here. And this left ventricle doesn't contract. Where's the blood go? Up to the left
Back to
atria.
the lung, yeah.
And then the pulmonary vein, I didn't draw the pulmonary vein, into the lungs. So there's where your pulmonary symptoms come. Again, think of the backup, think of the sink being clogged, think of that not draining appropriately, and you see your sink filling up with water. Same concept. My left ventricle is not contracting and going down the drain, it's going to go back into my lungs. That help?
Thank you. Yes, that helps. Thank you.
So is that when we're getting our pink frothy sputum then?
Audra, when you're thinking of pink frothy sputum, you're definitely thinking somebody, now I could be in left-sided heart failure and not be in pulmonary edema. Pulmonary edema is like the worst case scenario of left-sided failure. Pulmonary edema is like I'm full of crackles all the way up to my chin and I'm starting to cough up this pink frothy sputum. I can be in left-sided heart failure and have just a few crackles in the back, okay? So again, it's how severe that left-sided heart failure is. Pulmonary edema is worst case scenario. That's an emergency. We're gonna have to do some things, maybe even intubate the patient, send him to the ICU, but I could be on a general floor and have a little bit of left-sided heart failure. Depends
Okay.
on the severity.
Okay.
Anything
Dr.
else?
Palmer,
Yes.
is pulmonary edema the same thing as pulmonary hypertension?
Nope,
Different, okay.
totally different. Pulmonary hypertension has to do with the high pressure in the pulmonary artery. Let me say that one more time. Pulmonary hypertension has to do with high pressures in the pulmonary artery. And next semester, we'll actually have a hemodynamic lecture that we'll talk about and how we measure those pressures in the pulmonary artery. Pulmonary edema is my lungs are filled up with fluid because everything's backed up. The alveoli are full of fluid. I can't exchange gas, I could walk around with pulmonary hypertension, have some little bit of symptoms of right-sided heart failure. Pulmonary edema, significant left-sided heart failure. Full of secretions in the alveoli. I don't know if that answered it.
Yes, it did. Thank you.
Any other questions?
Yes, I have, Dr. Colmer, I have a question. With
Yes,
the
Barbara.
with the cardiac glycosides and the positive and negative ionotropic, can you explain that again?
So when they use the phrase, this is a positive inotrope, and you'll learn about more of them next semester because we use a lot of them IV in the ICU. But a positive inotrope helps increase contractility. So it makes a more forceful contraction. And we want that in a really sick heart failure patient, because the heart's contracting like this. We see this ejection fraction of 35%. It's really not moving because they did an echo, and the echo shows this ventricle that says, I don't feel like doing my job. So we put DIG on the scene and we make them contract stronger. That's what a positive inotrope. Negative dromotrope decreases the rate. So isn't this a great drug for somebody who's, one, tachycardic, right? We want to slow them the heck down. Two, have a crappy ejection fraction. So we give this DIG, for two reasons sometimes. Slow the heart rate down. People that are in AFib with RVR, we give it to help slow it down and help with that contraction. Say, well, I don't want you to fibrillate. I want you to contract nice and strong. Make sense? So that's what the inotrope means. It's a positive inotrope. It helps with, it's a positive effect. So it makes the contractility stronger. Does that answer it?
It does. It does.
Okay.
Thank you. Thank
Okay.
you.
Any other?
So Dr. Colmer, so when you just said that about the positive inotrope, so that doesn't slow the heart rate down?
No, no. It only has to do with contractility. The negative dromotropic effect, that slows the heart rate down. So if we say it's a positive dromotrope, which I guess epinephrine is, it increases the heart rate. A negative dromotrope slows it down. And we want to do that in somebody who's tachycardic.
So it's better, so it gets a better squeeze.
Right. Let me ask you this. If my heart's beating 150 times a minute, do I get to fill up and make a really good ejection fraction, like amount of volume I'm pumping out every beat?
No.
Okay. So if I'm beating really, really fast, I don't have the time to fill my ventricles. I end up with the decreased cardiac output. Do you see that? Okay. So we want to slow that sucker down and we want to make that contraction stronger.
Okay.
Slow the contraction down and make it stronger. Sorry, my Alexa's talking to me again. I have no idea what I say that makes her want to talk to me. So that, I would definitely, if you're not understanding the concepts of inotrope and dromotrope and chronotrope, I would definitely go to your medical dictionary that we had you buy and sort of read about that. But there are drugs that we give that affect rate, that affect rhythm, okay? And DIG helps slow the rate down, helps me contract better. So I have drugs that help with contractility, drugs that help with slowing the rate down. That help? I hope. Anybody?
Yes.
Yeah.
Bueller, I'm gonna start saying Bueller. You guys don't, you're too young, aren't you?
Some of us aren't too young.
Okay, all right, so.
Dr. Colmer, so you said that digoxin is a negative dromotropic drug?
Yeah.
Okay, so I guess I'm just trying to understand. So the positive inotrope just increases the rate of contractility, or like the
not rate. Strength. Remember I said we have this crappy ventricle that's just going like this. We want a better squeeze. So it's not, the inotrope has to do with how strong that muscle contracts. because I got a sick heart. I have a heart that just can't really do its job. So I want it to squeeze better, which would mean I'd get a better cardiac output. That makes sense, Ab?
I'm still trying to like, cause okay, so I don't know if I'm just like lost, but like for inotropes, they increase the contractility and then the dromotropes decrease it to make it slower.
No, dromotrope has nothing to do with contractility. It has to do with rate. Don't
Okay.
care about the contractility. I care about my heart rate's 150. Now I'm bringing it down to 70. So it does two things, you guys. It does two things. It helps with contractility. That's inotrope. And it helps with slowing the heart rate down. So it's two separate properties. Two separate properties. Okay. I was going to try to Google and show you guys. And maybe on a break, maybe we'll take a break and then I'll find it. But really take a look at your farm book when they talk about digoxin. I think that'll be helpful. The pharmacology book has a whole section on cardiac glycosides. That's a very important drug. I wouldn't spend so much time on it if I didn't think that it was important. For some reason, boards likes dig, and some old school physicians still use it. There are other drugs out there, but I still do see some digoxin being used. Questions?
Dr. Comer, what is the best way to tackle these like study?
Say it again. What is the what?
What is the best way to tackle these so we can study them?
Just like I'm talking right now, I'm taking you guys through a scenario and thinking about what does the drug do? What, ACE inhibitor, you all said preload and afterload, right? And you know that preload is the amount of volume. So that helps decrease the amount of blood dumped back into the right side of the heart, and it decreases afterload. Remember, let's start in the center of the heart. It's a sick heart. It can't pump effectively, right? Because if it could, I wouldn't be in heart failure. So it can't pump forward. It can't, thank you, Carly, for finding it, page 373. It can't pump forward, so things back up, right? Whether it's left or right side of the heart, and wherever that ends up. It can't pump forward. And we don't want a lot of resistance to even try to get the blood out of the heart. So that's that afterload concept. So we want to make sure that they have an effective contraction, strong contraction, so that they can eject the blood out to get a normal cardiac output. Okay. So when you, I think I did a roundabout way to answer your question, Cassandra, but when you're studying this, if you understand in that pathophysiology table or diagram that I have in my PowerPoint, which I said I absolutely love, if you understand what's going on with heart failure, you absolutely know why you're giving an ACE inhibitor or why you need to give a diuretic. So if you understand, I guess the starting point, Cassandra, is getting down the pathophysiology of heart failure. And then from there, the treatments and interventions make sense. You're like, oh yeah, they're short of breath and they've got fluid in their lungs, so I've got to give a diuretic. So really understanding, that would be my starting point, I guess. Please don't memorize the patho and think that I'm going to ask a patho question, because I'm not. You're nurses, you're doing interventions, you're taking care of patients and giving medications and assessing. So think of things that you have to do as a nurse, okay? Pathos for a whole nother class. When you go back to school, I took 3 patho classes and my master's, one of my bachelor's, and so that's for the future, like another class. But nursing is not going to ask you patho questions, but you have to understand it to understand the interventions. So she's feeling overwhelmed. Okay, and I get it, because heart failure is a big concept. It is a big concept. I definitely get it. Chunks at a time. Start with maybe, really going over the pathophysiology today. After we hang up, you go and you just study patho and you get that down and you understand renin-angiotensin aldosterone. You understand why the catecholamines get released and their heart rate goes up and all these things. And you go, oh, that's why I'm giving DIG. Oh, that's why I'm giving an ACE inhibitor. So I would say to you, Cassandra, little chunks at a time and start with the patho. Because the patho drives every single thing we do. If we anticipate these particular side effects or signs and symptoms, you know what to assess for. And then you see those signs and symptoms and you know what to treat it for. Somebody has diffuse crackles in their lungs, your brain says, I'm pretty sure a diuretic's going to show up somewhere down the line here. So making those connections. The other thing is when I study in the nursing process. I use the 5-column nursing care plan, and I write the assessment findings in the first column where that nursing diagnosis. What outcomes do I want? No, I want to talk about this because I read you guys' case studies. An expected outcome has to be measurable. So you can't just say, I'd like them to have normal vital signs. I don't know what that means. So, and that's where people I think struggles, because I say, all right, well, what would be the expected outcome for a heart failure patient? Somebody give me one. Somebody give me one with a decreased cardiac output as their collaborative problem. Somebody give me an expected outcome for that heart patient. Decreased cardiac output.
Like SpO2, nothing less than like 92% or something.
So an SpO2, 92 or greater, when? When?
On room air or like exertion. I don't know if that's
by the end of shift.
By the end of shift, thank you, Dawn. High five.
I don't want the end of the shift. So
okay,
sorry,
self-care
at all times, at all times, at all times. Any given moment you walk into the room, don't you, Lisa, want him to have a stat of 92? You don't say, hey, listen, I'm going to lunch. Feel free to drop down to 80. Do you know what I mean? So when you're talking about something that's absolute like that, you want that to be at all times. So I like that. And how do we know that? Well, you have to check their pulse ox every 4 hours or whatever. When you come to the ICU, it's continuous. So there's no, oh, I'll get it once a shift. It's continuous in the ICU. So we're constantly monitoring those things. Okay, so I like that. Give me another one. Patient will remain chest pain. Patient will remain free of chest pain every shift. How about at all times? You don't just say once a shift. You know, patient will have no chest pain throughout the hospital stay. Because we don't say, listen, I'm off tomorrow, feel free to have your chest pain, but when it's my shift, you can't have any chest pain. So you want to say throughout the hospital stay. Give me another really measurable. I'm waiting.
Okay, what was his diagnosis again?
Well, we were going with decreased cardiac output. And they had crackles in the lungs, and Lisa said, hey, I want the saturation to be 92 or greater at all times. That's fair.
How about patient will walk 20 feet today and 20 feet tomorrow, or 30 feet tomorrow?
So Nancy, that'd probably go with our activity intolerance nursing diagnosis, not the cardiac output one. And a lot of times students will do that is they'll dump a bunch of interventions that are for another collaborative problem. I won't use nursing diagnosis, collaborative problem. And that's a good one to do, because when you go to PCC, and I don't know if any of you, they have the little hearts and you say, okay, Mr. Jones, you're walking from point A to point B, that's 25 feet today. And guess what? Tomorrow we're going to try for 30 feet. And the next day and the next day. That's for activity intolerance because they can't tolerate the activity.
Maybe would a BNP, I think it's like less than 150 or something like that. That would show improvement, wouldn't it?
Oh, look at you. Well, you could do one of two things there. I like you're giving me something I can measure. Now, if somebody comes in heart failure, remember I said I saw it as high as 80,000. Remember that? Really high. Might it be unrealistic to get down to normal to go home? Because I'm better.
Well,
So depending. For me, I've never been in heart failure. You better believe I want mine to be less than 125. But like if we said something like, you know, and again, this is specific to the patient. If I knew it was 80,000, you know, by day 3, I'd like that BNP to be less than 20,000. Now, hell, if they get down to 1,000, we've even surpassed our goal. But it'd be unrealistic to say, hey, Mr. Jones, you're going to be normal by the time you go home. That's the realistic part of that's where you guys need to sort of like think about what you're doing and not just write, I'd like their vital signs to be normal. I'd like them to be stable. I'd like them to have a stable weight. I don't know what the hell that means. But if you say to me, listen, by the time of discharge, you're going to be down 5 pounds. Pretty realistic, right? I know I'm up 15 pounds of fluid, probably not going to lose the whole 15 pounds while I'm there. But if I'm down 5, you set that 5 as a realistic goal by discharge, and I'm 8, woohoo, I surpassed the goal, didn't I? But I met it. Don't give unrealistic goals of, hey, I want you to be down 42 pounds before you leave in the next 2 days. It's not realistic. So that's where how you need to like fine tune your outcomes. I'll get Katie, strict INO would be your intervention. Yes, it is an intervention. We'll get to the intervention. Give me another outcome.
Dr. Comer, can we use like Katie's for like the remain free of like chest pain, but like rated on like a scale of 0 to 10, like if they are having like continuous chest pain, like.
So you're going to do
something like
that in the
that?
you're going to do that in the evaluation. So,
Okay.
so I want my patient to never have chest pain. That's an absolute. Do you know what I'm saying? That's an absolute. However, in your evaluation, you go over here and you go, okay, well, I had them for the last 2 days and they rated their pain a 2 out of 10. That's exactly how I'd evaluate it. Healthcare provider notified that they had chest pain 2 out of 10 for 15 minutes. That's how I would make it specific and measurable in my evaluation.
Dr. Comer,
Yes.
how about something to the, I'm thinking, like patient will not require use of supplemental oxygen?
So again, let's go case by case scenario. Could we say something, because some patients might need it and it might be unrealistic to say that they won't have oxygen, but could we do something like patient will be weaned down from whatever they're at, let's say they're at 6 liters, weaned down to 2 liters by the end of the week.
Okay.
Now you come to me the next day, say, guess what, Lorraine? She's off the oxygen totally. I'm like, woo, we met our goal even earlier, but it's more realistic to say a small taper. But you, in your evaluation, you told me, Lorraine, she's done. She doesn't need any oxygen. That makes sense? You guys are missing a real simple one.
What about sodium restriction or?
Okay, that's gonna be an intervention. We didn't get to those yet, and I'll help you get to intervention question.
Oh, give us
Are
a
you
hint.
talking about?
Well, I'm talking about decreased
Okay.
cardiac output. So what do you want to know? Okay, Katie, I'm gonna come to you in a minute, in a second.
Ejection fraction?
Oh,
Okay, so I can't measure an ejection fraction, right? Because I'm a nurse
Right.
and I don't have a fancy machine.
Is it the wedge pressure?
No, I can't do that either. I can't do that either. Want a general floor. Can I take a heart rate and can it be between 60 and 100?
Yeah.
Yeah.
Okay, people, didn't I talk about the heart failure patient with the rapid rate? Here's a measurable goal. You don't say, I'd like their heart rate to be normal. I can't measure normal. But if you say, I want their heart rate to be between 60 and 100 at all times, not tomorrow, not the next week, not by discharge, at all times. If it's not in my evaluation comments, I say, oh my God, I had to notify the physician. His heart rate was 120. We had to give Cardizem. We statted him to the ICU, blah, 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 blah. So do you see how that goes? You don't use words like normal, stable, blah, 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 blah. Now, Katie put, they want to be free of edema at all times. Okay, that's fair, right? If they come with no edema. Now, if somebody comes in, and I had this patient that I took care of a couple weeks ago, and his legs were like this big, the ankles. He goes, oh, those are down. And I'm like, what? Like, they're like tree trunks. So they're chronically edematous. But I like where she's going with this. Could we do something like pitting edema will decrease from 4+ to 3+? And now it's measurable because you come over here and you do your assessment findings and you say, hey, listen, Lorraine, we even beat that. He's 2+. Excellent. It's probably unrealistic if somebody comes in with like 4+ pitting edema to go home with no edema, unless you dried them out like a rock. So it's probably unrealistic. That's what I'm going with, trying to make things realistic. I like that. If I showed up with no edema, I want to go home with no edema. If it's me, but these heart failure patients have edema. All right, so you guys see how you need to make those outcomes way more specific. Now you guys start talking to me, let's think nursing intervention questions. So what should be the first thing for this decreased cardiac output patient?
Daily weights.
Say it again.
Would it be like a daily weight or something like that?
Okay, so she's going with assessment stuff and I absolutely love that. So daily weight. Don't tell me I'll get her weight. Daily weights in the morning at the same time. You tell your patient to do that. Okay, go ahead. Give me another.
Fluid restriction.
Like what? Like how much? What are you
like
thinking?
Maybe 1,000.
Okay, so you can say 1,000 liters, 1 liter fluid restriction per physician, healthcare provider's order, right? Remember, you guys don't have to determine it. Your job is to reinforce it. Okay, I like it. So we got a fluid restriction. What else?
Assess BP and heart rate.
I love it. So how often you doing that, Trish?
Every 4 hours.
Okay, I like it because you all are on the intermediate, so I hope you're saying that. So every 4 hours, I would even just be very general and say vital signs, because didn't we just talk about that patient who becomes hypoxic, their respiratory rate goes up. So vital signs, Q4 hours. Perfect. Okay. What else are we assessing?
How about peripheral pulses?
Oh my goodness. Thank God somebody finally said it. So if I have a decreased cardiac output, I have a crappy cardiac output. Do I have good pulses?
No.
No.
Why not? We're not perfusing, are we? I'm not getting that strong contraction to get the blood out. These pulses are 1+, let's say that. So what she's talking about is getting those peripheral pulses. So we should assess them how often?
Same as the vital signs?
You got it. Every 4 hours, you got it. So do you guys see that? So because the peripheral pulses, if I started my shift with a 3+ peripheral pulses all over, and now they're 1+, their heart failure is getting worse, right? Because now I'm not even getting anything out. Like I could barely feel a pulse. That's a really good way to tell cardiac output. If I can't feel a pulse, hello, isn't that the first thing you check for CPR? You get a pulse, right? So same concept is assessing the peripheral pulses every 4 hours. What else?
Assess for jugular vein distension.
Every 4 hours. Keep going.
The urinary output,
How often you doing that, Audra?
at least an hour, so 30 mLs, at least an hour.
Okay, so you gave me a really good outcome. Patient will maintain a urinary output of 30 mLs an hour at all times, right? Because when you come to the ICU, we do hourly outputs. We don't wait to the end of the shift to figure out if they've not made urine. So you gave me every 4 hours, what is that, 120, 30 times 4? Yeah, 120. Patient maintains a urinary output of at least 30 mLs an hour or greater, right? That's a great outcome. How do we measure that? Well, we're going to go and we're going to do Q4 hour outputs, strict INO. We're going to document everything that goes in, everything that comes out. Everybody with me? Doesn't that make sense? Okay, I like it. What else? You guys are missing 2 really important ones.
Assess heart sounds and lung sounds every
Thank
4 hours.
you. Yes. So we're going to assess. Now I'm trying to make the connection for you guys if you're not paying attention. So I'm assessing heart sounds and lung sounds every 4 hours. Why am I doing that? What am I assessing for?
Crackles.
Crackles.
Yes.
Any changes or worsening too, yeah.
Okay, so Jalea says, I'm going to look for an S3 in crackles, right? And then you say, oh boy, that's left-sided heart failure. Do you guys see how we get to this? So you understand the disease process. You think about what you want to happen with your patient. Now these interventions are when we get all that assessment data. And we're like, oh my gosh, they got crackles. They didn't have crackles yesterday. Now they have crackles. Oh my gosh, I hear an S3. I've got to notify the provider because that's a change in the assessment. And maybe yesterday they were just small little bibasilar crackles and now they're diffuse. Absolutely comparing, and that's why you guys should be looking at the RNs before you use assessment to see if you get the same thing. I like where you're going, Nicole, with the alert and oriented. Why do I care about that?
Electrolytes and like if there are any changes.
Hypoxic
nursing
and low heart
diagnosis.
rate.
She said it. Confusion and decreased perfusion. If I don't have a cardiac output, you guys, I'm not getting blood to my brain. Am I getting confused? Yeah. So do you see how if you assess for these things, you know what's going on. So understanding those assessment findings makes that connection. Are you guys seeing this? Is this helping?
Yes.
Oh my God, I hope so. Okay, all right. So, okay, Dawn says, I'd like to get a BNP, and Dawn is not wrong. We don't normally get them daily. So I would write something as an intervention, BNP per provider's order. If he comes in and you say, hey, provider person, your crackles are 10 times worse today, they're coughing, they are more short of breath, he's going to say to you, get a BNP right now. So you need to be prepared, and that has to be on your radar. Chest x-ray, absolutely. Absolutely. I can't tell you how many times I go with my renal doc, he goes, get a chest x-ray. And I'm like, okay, I wasn't even thinking of that. You know, you're renal. But, and we did 10 o'clock in the morning, we got a chest x-ray. So you write per provider. So that prepares you to anticipate that you potentially might need to get a chest x-ray. I like it. Okay, so I think we did a good job assessing. We did peripheral pulses, we did the vital. Did anybody get a pulse ox? No, let's get a pulse ox. We set an outcome to have a SAT greater than 92. So whether it's an intermediate Q4 hours or it's ICU continuous, when in Rome, do as Romans do. So you guys are in the intermediate, so it'd be Q4 hours.
You added that to the vital signs.
There you go. There you go. All right, anything else with assessment? Look how many we got just an assessment for decreased cardiac output. Do you see this? And I love when students come in my office, they go, I don't know what to write for interventions. What do you mean I got to do 10? Did we just do about 10? I think we did, right? We didn't even get into the meds. We didn't even get to the meds. So, all right. Questions on assessment of decreased cardiac output in a heart failure patient. Did we miss anything? Nope. Okay. Oh, so Bernie says, listen, well, what about this echo? Well, let's put that under that lab with Dawn's BNP and chest x-ray. 100%, Bernie, they're going to get an echo because they want to know what the ejection fraction is, and they want to know how well those valves open and close. 100%. Echo per provider. EKG, I like it. Absolutely. If we have a bad rhythm, right? Absolutely. They might even be on cardiac monitoring. Aren't your patients in PCC or whatever units you're on? I like it. Okay. Talk to me about meds. Kidney labs. I like it because if I have a decreased cardiac output, am I perfusing my kidneys? No. So BUN, creatinine, GFR. Dawn says, I'd like to give diuretics. Okay. So again, understanding the differences between a loop, potassium or thiazide, more often than not, if it's IV, and no one's going to ask you this, but if they're acutely ill and they need to be IV, it's going to be a loop. No one's going to ask you that as a test question. So let's see. Skin. Oh, I like it, Tricia. She said, well, the skin will be cold and clammy. Well, can't we assess the skin temperature? Right? Yes. Do the 6 Ps. Capillary refill. All those wonderful things tell me I'm not perfusing the body. Okay. So you guys are giving me some great drugs. So when we're talking diuretics, you should be looking for the output. One of the first things I always tell my students in the ICU, if you give something IV diuretic or even a diuretic, empty the Foley bag completely so you know exactly what kind of response to the diuretic you got. You don't want to mix urine that was before the diuretic. So you're going to empty that bag because sometimes people will spill over 2,000-3,000 a urine. Okay, so you definitely want to say to the doctor, hey, I gave that Lasix and they put out 1,000 milliliters of urine. Okay, so understanding the differences between the diuretics, excellent. ACEs, so those prills, right? And we just talked about those, so you know that. Thiazide diuretic, absolutely, you could do that. Digoxin, remember, think of all of those things about dig toxicity. What is your patient saying to you? What do you need to teach the patient? Okay, let me think what else. What happens if you give Lasix? Excellent question. So she says, what happens, double check the bottle, make sure it was a diuretic that you get, no, just kidding. So she said, what happens if you give it and they don't diurese? Well, first and foremost, you need to call whoever ordered it and tell them that, because now we have a bigger problem. Are they in kidney failure? Do we have some significant thing going on? So again, if we're not getting the desired response or the desired effect of that diuretic, call somebody. So Bernie says, should we bladder scan? Absolutely, if they don't have a full in, because it would drain. And two is, are they complaining of their bladder? Because they could be retaining. I'm not against that. The other thing is, and this happens a lot, they're like, what, they didn't make any urine. Well, they're a dialysis patient. They don't make urine. So if you had a resident that ordered a diuretic and they're in end-stage kidney disease, they may not make urine. So really knowing your patient's medical history is going to be helpful. But yes, can you bladder scan? Absolutely. Oh my gosh, there's 3,000. We need to straight cath the patient. Beta blockers, yes, but remember in acute heart failure, we won't probably start them on a beta blocker. Might be something later when they're a little bit more stable. And then Carly wants to do SCDs. Now, Carly, why am I nervous about doing an SCD? I get where you're coming because you're thinking of the edema. But what will the SCD increase? Where's Tori?
Preload. It's
There
going
you
to run.
go. So definitely preload. So do we want to dump a bunch of that back into the heart and tax the heart?
No, I just killed them. Sorry.
No, you didn't. No, because I have put them on people. It's a long story, but I wouldn't probably use that as a first treatment. I know where you're thinking if somebody's acutely ill and in bed and not moving, we can get a blood clot and all those things. So let me just say this. I have put SCDs on heart failure patients. I have. But if you're just strictly thinking about that preload issue and they're in acute distress, you may not. Don't get me wrong. You can use SCDs.
Thank
Okay.
you.
Yes. What about educating them? What are you going to educate me about? What are those initials I told you about?
Weighing themselves daily.
Keep going.
Sodium.
What about it?
The DASH diet.
Okay, I like it. I like it.
Medication.
Medications and how to take them correctly. Let's go back to the sodium. So what are you going to tell me?
Under 2,000 a day.
Read the labels.
Say it again.
Read the labels.
Audra says, listen, read the labels. Well, I like frozen.
Stay away from canned goods and frozen.
Oh no, I like canned goods. I want canned goods and pickled beans. I hate pickled beans. So pay attention to different things. Like my mother-in-law loves pickled beans. And they're full of salt. Anything pickled, no. And she's hypertensive. So you really, I know, gross, right? I think the same thing. So you really want to talk to them about their food preferences. Oh, of course, Dawn would like the pickled beans. So you really want to talk about the food preferences with your patient. Goes with grapefruit juice, gross, yeah. So frozen dinners, soups are a no-no. Now you're talking. This is the stuff you need to say to the patient. You don't just say, hey, watch your sodium. Okay, I'll watch it go on my plate. You want to say, read the labels like Audra said. You want to say, watch those canned goods, rinse them off. You want to say, yeah, bad foods are cheaper, 100%. And I like that, Bernie. What resources can we get for the patient if they're on a fixed income? Because she's absolutely right. Some of the bad foods are cheaper. I think of like my son, he loves those ramen noodles when he was in college. Oh my God, it's like 4,000 grams of sodium in those things. Fluid intake at home, a type of, yes, definitely, Dawn. Fluid intake, maybe getting them the cup, measuring, really explaining to them how much they can have a day. Because, if I say to my mother, you need to increase your fluid, she doesn't know what that means. Okay, good. What else? Anything else? Smoking, yes, definitely. Keep your follow-up. Yes, pace yourself. That's exactly right. Don't weed the garden, cut the grass. Take a 50-minute walk, pace yourself, exercise with rest. Yep. So you guys know this. All right. I'm going to segue. Let me go here, share. Maybe I'm going to share. There we go. Here we go. Can you guys see that?
Yep.
Okay. So let's go to this clinical case. And I love Nurse Tim. I actually got to meet him at a conference, and he's, I don't know, he's best friends with one of the NCSBN, the board's people. So I tend to listen to what he has to say and what he recommends. So that's why I like to use his cases. So William Jones, 69-year-old man with a 25-year history of hypertension.
Come on.
So he's discharged from the Veterans Hospital last week after a 2-day stay for hypertensive crisis. So before we go any further, what does he have a problem with, preload or afterload?
Preload.
Afterload. High blood pressure that resists preload's volume. Hypertensive. He has high blood pressure. Lots of afterload. That heart's working so darn hard to get that blood out because there's so much resistance to get through that aorta. Okay. All right. Home care nurse is making a visit. Mr. Jones greets the nurse at the door. He's tall with a large build. He walks with a limp and is mildly short of breath. His home is small but neat and well kept. There are no stairs or throw rugs. He has a small dog barking as the nurse enters. The smell of food is cooking from the kitchen. Okay, so the nurse performs an environmental assessment. Which observation listed would be a potential concern and for further assessment by the nurse? So what do you guys think about his large build? What do you think?
Overweight.
So what do we need to assess on him?
His BMI is probably up there.
Okay, so we definitely, as nurses, we're gonna assess that BMI. I like it. So we wanna know the height and weight. We're gonna ask him that. We're gonna assess the height and weight and calculate the BMI. What about walking with a limp?
So if he is like overweight, it's gonna put like more stress on his lower like extremities, and two, he might have like poor perfusion from it.
What
Or
else?
maybe ask what happened, why he's walking with a limp, like, you know, if this is recent, how long it's been going on.
Okay, but what are you most concerned about?
I was thinking about possible peripheral
Oh.
vascular disease, maybe.
Okay.
I don't know.
I'm worried
Okay.
it could fall.
Who just said fall? Fall.
Falls.
Yes, you guys are all bringing up excellent ideas of like, why did that limp show up? What is going on? But really the priority right here is to keep this man safe. And if you look up in his tissue, they're like, there's no stairs, no throw rugs. They're already sort of setting the tone of issues of that we're worried about with these patients being in their home environment. Okay, excellent. What about mildly short of breath?
He got up to answer the door, so with activity, he's short of breath.
Okay, so he's got a little bit of activity intolerance. What should you as the nurse assess then?
Lung sounds, SpO2.
Vitals.
Absolutely, because let's go back to that comparing in the assessment findings. You know, he didn't have any crackles yesterday and now he's got crackles midway up. Now we have a problem. Do you guys see that? What about the small dog other than that's like a cat? So, you know, you got to get a big dog, not a small dog, but that's just my preference. What about the small dog?
All risk again.
Absolutely. Sorry. Do we tell him to get rid of the dog?
No.
No, I mean, we're not mean, but I just aspirated seltzer. We definitely want to pay attention to that could be a risk for a fall. What about the smell of food? What do you think about that?
We're checking to see what he's cooking.
Oh, what do you want to know about what he's cooking?
If it's like healthy or
Sodium intake.
So you could, that's exactly, you can really do a dietary intake. Hey, what are you making for lunch? Or what are you cooking in there? That's absolutely right. Okay. After
I also
completing-
put making
ahead.
sure that he knows that he's cooking.
Oh, what are you worried about?
His orientation, like he knows, like if he's alert and oriented, that there's
Okay, because people do leave stuff cooking on the stove, don't they?
Fire hazard.
Definitely. Definitely, excellent. After completing the initial paperwork, blah, 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 she documents the finding using a tablet. Okay, great. Here we go. And this right here, guys, this is called an exhibit kind of question. When you go to take boards, you can click on these tabs just like you're reading in a patient's chart. So that's why I'm trying to show these to you, so these aren't foreign to you. Okay, 69, blah, 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 blah. He has an enlarged prostate, 25 years, hypertension, diabetic, surgical history. He had his gallbladder out and orthopedics for a blown out left knee in Vietnam at the age of 20. Lives with his wife, his high school sweetheart. Aw, but like he's real. Vital signs, as you can see here, respiratory rate 22, heart rate 110, and look at the blood pressure. This number right here, this 115, is called a mean arterial pressure. And we're going to talk about that next semester. Mean arterial pressure is a better indicator of how well we're perfusing organs. So his mean arterial pressure is really high. So it's a lot of pressure against those organs. Hence why kidney damage occurs with hypertension. SAT 93 on room air, alert and oriented. A lot of places use ×3, we use ×4, so this is okay. I just want you to know that. Moves all extremities. Question? Nope, okay. Grips and pushes equal, so he has equal strength. Left leg weaker than right, and his knee swollen. Remember, he blew out his knee in Vietnam. Pain is a 5, so that's moderate pain, guys. Pulse is strong, S1, S2, S3, right there. Heart sounds with irregular beats, and he has crackles. States feeling shorter breath with activity, bowel sounds 4. Last bowel movement looks normal. Hesitancy, remember he has an enlarged prostate. He has an enlarged prostate. Up to void 1 to 2 times a night. And with blood sugar out of control, you could be getting up and peeing in the night too. Checks it daily. He's 6'1". Look at his BMI. Okay. So tell me the 3 priority problems. Number 1.
The elevated blood pressure.
Yes. So high blood pressure. Boom. Good. Next.
S3 sound.
Okay. So I heard S3 and what was the other thing that you just said?
I said uncontrolled diabetes.
Okay. All right. So glucose, that uncontrolled diabetes. Let's add the other things that go with that S3. What else, guys?
He's tachycardic.
Tachypnic, tachycardic, crackles, low oxygen sat. They say low 93. You know, if he has no underlying lung disease, we should be 95 or higher. Okay. So we want to watch that 93. I'm not losing sleep over it yet, but we're going to watch that 93. All right. So here's his meds. I'm sorry, I'm going too fast. There we go. So here's his meds. So the first one's a what? Lisinopril is a
ACE inhibitor.
ACE inhibitor, and it decreases
Your preload.
and
Afterload.
thank you.
And
Yep, atenolol. What kind of drug's that?
Beta blocker.
Beta blocker. Excellent. And what are we worried about giving beta blockers?
Cardio receptive or non-cardio receptive.
So, well, the different types. Okay, but what are we worried about? What do we assess?
For COPD and asthma.
Their pulse.
And blood pressure.
Okay, so for the beta blocker, we assess the pulse and the blood pressure. I think we did talk about the issues of people with COPD or asthma. We're very concerned about giving those. Don't get me wrong. I've had COPD patients on a beta blocker. Metformin, why am I taking that?
Diabetes.
Yes, yes. Tamsulosin, why am I taking that?
The prostate.
Prostate.
Yes.
Enlargement.
Yep, for the prostate enlargement. And then the last one, Celecoxib or Celebrex. Why am I taking it?
Anti-inflammatory.
NSAID.
Or is knee pain.
Very good. Okay. Always compare the actual, this is very true. You want to make sure, we just did this with a family member and he had 3 different types of SSRIs and you shouldn't be taking 3 at the same time. So we're hoping that he didn't inadvertently take them all. Do you see what I'm saying? So always compare what the actual bottles say and what the order is from the physician. Okay, 3, or provider. After further inquiries, discovered no morning medications have been taken. Which one should he take now? So they're asking you priority things. So think about the priority ones. Which ones are a priority? What do you want to give?
Lisinopril,
Okay, so number 1,
Atenolol.
lisinopril, circle. Atenolol, circle.
Metformin.
Absolutely, metformin, circle.
Necilbrix.
And
then,
Celebrex,
yeah, I think the
excellent,
Celebrex
yeah.
because of the
Yeah, the
pain
prostate one, we're not gonna lose sleep about. The prostate one, we won't lose sleep about. But the Celebrex, he's got a 5 out of 10, guys. Okay, he's got a 5 out of 10. So you really wanna pay attention to that.
Hey, Dr. Colmar.
Yes.
So since he's taking the atenolol, and isn't that the one that like masks the hypoglycemia, like signs of it? So if he was to like take metformin and like his sugar comes down, like, will that decrease? That won't like decrease it, but it'll just like, if it gets too low.
It'll just mask the symptoms. So you know how people get real hangry and sweaty and sometimes a little bit of confusion. You might not
Right.
see that and their sugars drop. So the smart nurse grabs finger stick. You can do that without an order, you guys. So if you say, and that's a good point, that you're like, oh my gosh, he's on the, this beta blocker and he's a diabetic and he takes, I'm gonna make sure I get, blood sugars and pay attention. And I always play dumb with the provider. I always go, so like, do you think you need to get a blood sugar at any point in time? They go, oh yeah, great idea. So most of the time we're pretty vigilant in the hospital with getting sugars, but you're absolutely right. Pay attention to those things because you might not see those very typical hypoglycemic episodes. Okay. All right. So why did we pick? So why are we giving the lisinopril and the atenolol? What do we want it to do?
Bring down his blood pressure.
Yeah, that's exactly right. And what's the atenolol also going to bring down?
Heart rate.
His heart rate.
There you go. This heart rate. That's exactly right. Because he's a little tachycardic, wasn't he? And hypertensive. And then the metformin, because that blood sugar was 178, wasn't it? And then because of his pain, he's a 5 out of 10. So that's why I would pick those meds. Let's look at number 4. Now I want to show you, do you see how there's 6 responses there? I hear that on NCLEX there could be up to 7. Okay, so just so you're prepared for that. That's why there's 6 responses there. So, and all 7 could be right or only 1 could be right. So don't get stuck on a certain number that needs to be right.
Oof.
Yeah, I'm sorry. I'm just giving you a headsy upsies. The nurse completes a falls assessment risk for Mr. Jones. His score is of 13. At risk is greater than 10. So he's always got, yeah. Which interventions would be most appropriate? Are you finding him a new home for his dog?
No.
I hope not. He would be very sad. What else? What do you want to do for him?
Physical therapy.
I think that's a great idea because doesn't he have that limp and what the heck's going on? And maybe they can help him ambulate safer. Okay, so physical therapy. What else?
Grab bars in the bathroom.
I like it, right? To be able to get up and down, not to fall.
Brace for his knee.
I don't know if he necessarily needs a knee brace. So they're saying it's not necessarily a need for him to be braced.
Did he blow his knee out?
But his knee, he had surgery repair, and that was 20 years ago. So it might not necessarily mean that his knee needs brace. It could be he has a bad hip now too. So getting that physical therapist to come and do that evaluation to figure out why he's limping. Is he limping because of the knee or is it a hip issue or a back issue? So really having that therapy referral and then go from there, but they're saying no. Placing a red falls wristband on. Now this is interesting.
I picked that.
I wasn't sure because like he's at home.
He's at home, so don't.
Well, yeah, after the fact, I'm like, well, yeah, you got to put a falls wristband on everybody. Duh.
Home assessment. Yeah. There you go. Because that's right. That's the first thing I did. I was like, well, yeah, he has a risk for falls, but he's at home. Okay, 5. The nurse reviews Mr. Jones' advanced directives. The forms indicate he's agreeable to everything except being on life support. He's identified that his wife is his POA. How should the nurse interpret his preferences? So give me correct answers. Is 1 correct?
Yes.
Yeah, right? She's his POA, 100%. Yes, that's correct. What about 2? Should we do it or not?
No.
No, that's life support. That's a ventilator. That's supporting his ventilation. So scratch that out. 3. Isn't that life support too? Didn't you take basic life support and use a defibrillator? Scratch that out. Provide nutritional support if he is in a vegetative state.
I would say no, because that would be like life support in a way, because
It's not actual life support when he's saying being on life support. So you can, this is where it gets kind of iffy, you guys. So yes, I can feed this patient. I worked in a nursing home and took care of many patients that were in vegetative states that had tube feeding. It is not a life support like a breathing machine or CPR or anything, like if they've stopped their heart. This is not considered life support, so you can give it. However, the smart person that you put as your POA, you tell them whether you want that or not and delineate that very specifically and have them say absolutely no nutritional support as well. Perform CPR if found unconscious and not breathing. Isn't that life support? Now, here's
I have a question about that.
Here it gets a little, I was just going to say, here it gets a little tricky. I could do CPR, okay, if this is the question that you're going to have. And let's say I start CPR and I'm at home and he has spontaneous return of circulation and he's not placed on a breathing machine and he's okay. That could happen, right? Everybody agree with me, right?
Yes.
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 But I know
No,
there's
wait.
a but there.
There's always the but. So the CPR in of itself is not life support. Here's where it gets kind of ugly. As I'm doing CPR, one of our very first steps is to intubate a patient, at least in a controlled environment in an ICU. That's the first thing we do. We intubate the patient, we manually bag them. So I could do CPR in the home. At some point in time, if he does not progress or return circulation, then we got to let him go. But I can initiate CPR, but I'm not going to put him on isn't that kind of weird?
So then it would be like having a DNR form signed separately then, or?
So, and here's where I have problems with the DNR form. So we have in the state of Ohio, the DNR CC, DNR CCA. So CC is comfort care. We don't do anything. Your heart stops, you stop breathing, we keep you comfortable. CCA is up until the point I arrest. So if I'm in the ICU, my blood pressure is low, I can treat that. If I have some breathing problems, I can intubate. I didn't stop breathing, I just had breathing problems. I can intubate. But if I totally stop breathing, I can't intubate. Do you see where it gets to be a gray line? So it's a little confusing. So I always say, tell me exactly what you want. And they'll put in patient doesn't want a breathing tube ever, so they'll write that in the notes. We have to be very clear because there's a lot of gray lines there. I don't know if that answered your question.
Okay.
Yeah, I mean, it's a hard question to answer, I guess.
Very confusing.
Hello, welcome to the state of Ohio. I'm like, so wait a minute. We could do everything, we could do meds, but we can't do, so I can push meds into a patient, but I can't circulate them. No CPR, but give meds. I'm like, okay, I'll do it. So
Okay, Lorraine, I have a question when you're done.
But no, but I think we need a lot more education. Like, if you don't pump the heart to get the medications to get through the system, it's not going to really help. Go ahead, what's your question?
So there's a gray line. So say that patient is found unconscious and not breathing. You don't know how long they've been unconscious for.
Can't make that
So-
assumption. Can't start CPR.
So with that being said, no oxygen's getting to the brain.
Correct.
Using CPR, they come, you know, they start breathing eventually, but they've got some sort of brain damage. I mean, you're like in a catch-22.
Oh, I can't tell you how many times that's happened to me. Patients were found down at home, drug overdoses, and we don't know how long they've been down, and they come in, you know, and of course, the return circulation, that, you know, we got them on a breathing machine. At this point now, we have them breathing machine in the ICU. And we have no idea how long they've been anoxic until we do that EEG, and then we see that there's no brain waves, and you're like, oh my gosh, how terrible. So then that conversation is withdrawing treatment. So there's a lot of things that can occur in that short period of time.
Hey, Lorraine,
Yes.
for that question, for number 5, it says, number 2 says no intubation. Should he stop breathing? So that'd be an option, right?
So yes. So if he says, and see, that's where that CC and CCA part comes into play. CCA is if he just stops breathing, we don't intubate. If he has respiratory distress and he doesn't stop breathing, but he's in a lot of distress, I can intubate. Isn't that weird? That's the law in Ohio. That's not what he's saying there. He just doesn't want to be put on life support.
So is that the same as like giving them oxygen too? Like, I know it's like not intubation, but like.
You can give oxygen.
You can give oxygen, okay.
And see, that's why I wouldn't use the term life support. I'm very specific when I talk to families. I'm like, do you want a breathing machine to do the breathing for him? Tube stuck down his throat. Like because life support is just the sort of lofty general term. And I think it makes it very difficult for people to really make an educated decision. So I'm very, very factual. Do you want us to shock him? Like we're going to turn on a machine and shock his heart? Oh, no, he wouldn't want that. Okay. Do you want us to compress his chest? You know, so really having a very, very honest and very, not graphic, but descriptive discussion, because life support, too general of a term. I don't know what the hell that means. What concerns did the nurse not address on this visit? So number 6.
Exercise and diet.
So yeah, dietary education, excellent. What about the irregular heartbeats? Remember he was irregular?
Yeah. Just that or the crackles.
Right. What should she have requested an order for?
Chest X-ray.
Chest X-ray.
Echo?
I'm at home.
Diuretic.
Yes. And what else should the patient maybe do to keep an eye on that?
Teach him how to manually assess his heart rate.
Say it again.
Teach him how to manually assess his heart rate, his pulse.
Oh, okay, that's fine too. I was, whoever said daily weight, because we're giving that diuretic. You got to see that response. So you definitely got to see that response. All right, 7. 1 week later, Mr. Jones calls the home care nurse saying he's feeling very short of breath since he awoke 3 hours ago and having a hard time breathing. What action should the nurse take next? So
Call 911.
Yep, hang up the phone. Stop talking to me. Because again, he hasn't stopped breathing. We can treat him, right? We can give him oxygen. We can give him a diuretic. He hasn't stopped breathing or gone unresponsive. He chooses to, oh, that's great. His wife to drive him to the ER. Sounds like my father. Okay. Oh, look at that blood pressure, you guys. And the heart rate. And his SAT now. And his respiratory rate. And look at his crackles. So I would have circled this bilaterally, anteriorly, and posterior. What are you guys thinking?
He's a heart attack gonna happen.
What's
Wow.
Pulmonary edema.
Hypertensive emergency.
Yes, pulmonary edema, because he has such a high, what load? High
Preload.
No!
Afterload.
Afterload. Look at that blood pressure. Look at that blood pressure. That blood
This is
pressure.
the resistance, right?
Yes, that heart goes, I got nowhere to go. I'm just gonna back up into the lungs. It can't get out. There's too much resistance. So that afterload, we gotta reduce that afterload. We gotta get that sucker down. Now, don't get me wrong, you might have fluid too, but this is really looking like left-sided heart failure, right? Crackles, moist cough. He's probably going into pulmonary edema. All right, 8. What are you gonna do? What are you gonna do? Give me some interventions.
Oxygen.
Okay, but what could we do first that I said we're nurses, we're in the room?
Get his head of bed up.
Raise the head of the bed.
Raise that head of the bed, get his head of the bed up, give him some oxygen. What else you gonna do?
Put him on a monitor, cardiac monitor.
You could if you got one, yep. Next thing you're gonna do, last thing is call for more orders. Because now you got their head up, you got them on oxygen, now we need some more stuff, right? Now we need more that we're gonna talk about right in this next question. So number 9, discusses the situation with provider. Which prescriptions should the nurse question? Meaning, uh-oh, not a good idea.
Number 1.
So saline at 100, is that a good idea for somebody who's short of breath and probably in heart failure?
No.
Bad idea, bad idea. Okay, I like it. What else you want to question? You might not get this one.
I was feeling like the oxygen at 15 liters. I don't know if that would be too much too fast.
Ah, excellent choice, Haley. That's exactly right. Do we need to go right to the big guns? Maybe not. He was 90, wasn't he? Put him on a couple of liters nasal can. So we're not going to start at 15. You absolutely right. It's a drug. Start low and increase as needed. So you're right. You went right to the big guns. We don't need that. Let's start with a nasal cannula. What other one would you question?
Was
that like, yeah.
Lasix. I mean, if he's in risk of pulmonary edema, you need to get that fluid off before you can really get him to oxygenate, right?
Yeah. So what about the Lasix? I'd question it
5
too.
milligrams
It's
is
not
like
big.
giving him a Tic Tac.
It's not gonna do anything.
Not enough.
Exactly what Dawn just said. It's like giving them a Tic Tac. So a standard dose is 20, maybe 40. I've given as much as 80. So that is like spitting in the ocean. That's not going to help him. So I would think,
the ocean.
what's that?
I never heard that saying before.
Yeah, you spit in the ocean. It doesn't matter. No one knows that I spit in the ocean. So really knowing your doses. So again, it's July. We have brand new residents. They're so excited to write orders and they write this 5 and you're like, I don't know what the hell you're talking about, but that's not a standard dose. So, all right, let's go to the next slide. Oh, we got gases. Yay, I love gases. Okay. So, oh, and he gave you the L's and the H's. What are you thinking is going on here?
Respiratory acidosis.
Respiratory acidosis, right? Because if you look at your pH 728, it's low. Your oxygen, he's hypoxic, it's low. And then CO2, he's retaining. So he has respiratory acidosis. And look at his SAT, 91. And he's only on 2 liters. So now, Haley, what are you going to do?
Give him O2. Increase it.
O2. He's on 2. So maybe we go up to 4. Okay, or 6 or whatever. But yes, he's in respiratory acidosis and he needs more oxygen. Here's your handoff report. So he's coming from ER to the unit. We gave him the now dose of, oh, he got 40. Thank God somebody corrected that. That's a standard dose. 10 minutes ago and started him on, nitroprusside. Do you remember me talking about that in the hypertension lecture?
Isn't it only given IV in the ICU?
That is correct. That is correct. So you could see he's on mics per kilogram per minute. Do you see that? And it's a continuous drip. So that's that, I used to call it Nipride, but they call it NitroPress or something like that. So again, this is a very seriously ill patient. He's going, look at his heart rate, 120, 211 over 115. And now he's having some PVCs. Okay, and there he goes. He's going to the ICU. So here are our orders, and we want him 94. And again, that's up to the provider. Okay, that's up to the provider. We're gonna get CBC, CMP, BNP, look at that, chest x-ray. We're doing blood sugars. Now, do you see this is very common? This systolic 160, diastolic less than 90. Those are your parameters. I can fiddle faddle with that drip to get my blood pressure to those parameters. I don't have to call anybody to change the dose. That's what you're going to do next semester. You're going to run drips that are titrated based on the parameters that the physician gives you. So he wants that systolic less than 160 and the diastolic less than 90. And if you get up to 10 mics per kilogram per minute, you're going to have to call him. You're going to have to call him and say, I maxed out what you said. What else do you want to do? Okay. They gave Lasix 40 now and again in 8 hours. Got him on his metformin, Tylenol for a headache, done a ADA diet, low sodium, and see, it's not real specific. Put a catheter in because we want strychnine and then baseline and daily weight. So he's in the ICU. Head of the bed elevated. See, the nurse even charts that. Head of the bed elevated. O2 at 4 liters. SATs 92. Crackles bilateral 3+ pedal edema. Positive for neck vein distension. Blood pressure here. So he's on the medication to bring it down. He's got a headache from that medication. Okay. Take a look at his blood pressure. So this is on admission. It only went down to 210, half hour later. So do you see they're not waiting to take these pressures, and he increased the drip. Headaches of 4. Gave him some Tylenol, cool cloth, voided 100 of urine. Uh-oh. We gave that diuretic and all he voided was 100 of urine. Okay. BMP still, or the BP still over 200. We're still running at this dose. He's resting quietly. Look at his potassium. Look at his BUN and creatinine. So now we've got some kidney disease here because of decreased cardiac output. And his brain natriuretic peptide is 452. Oh, we finally made 500 of urine. Slight headache is dull. 192 over 100. We're getting better. And then getting more PVCs, 4 to 8 a minute. So that potassium, I make that connection with PVCs as well. A low potassium will make me throw PVCs. Blood pressure down. We're still at 2 mics. Oxygen 4 liters, crackles in the lungs, glucose 190. All right. So after reviewing the last 2 hours, which prescription did she not complete correctly? What didn't she do correctly?
The oxygen.
You got it. So she didn't titrate it because SATs were not maintained greater than 94, were they? It was 93, I think. Good. Give me another one.
Complete lab draw. She didn't do like a CVC.
Are you sure? Lab report noted at 1630.
What about the nitroprip?
She kept keeping that patient. Well, we're calling her she. I don't know if he or she. She kept that patient on 0.2 forever, didn't she? She never changed it. She never got to the parameters of systolic less than 160 and a diastolic less than 90. She did not titrate that appropriately. Okay, good. What else?
The indwelling catheter.
Right. He voided, didn't he? What the heck? What was she doing? Okay. Which priority data collected by us should be communicated to the healthcare provider? What should she have communicated?
The lab.
1 and 3.
Yep. So the 1 is expected because he came in with the crackles and the edema. That didn't change. The labs, though, because we need some orders for that, right? We need some new orders for that. 13. So an S bar, let me take a look. I'll read this to you. S. Hi, Dr. Kumar. This is the nurse caring for Mr. Jones in the ICU at Nurse Think Healthcare System. I'm calling because his abnormal lab results. His potassium was 3.3, BUN 32, creatinine 2.3, BNP 452. B. He came in with hypertension, has recently been diagnosed with heart failure and received furosemide 40 milligrams about 2 hours ago. He's voided 600 milliliters of clear yellow urine. A, on the monitor, he's having increasing PVCs 4 to 8 a minute. Blood pressure is 195 over 101 with a mean of 132. And nitroprusside continues at 0.2 mics per kilogram per minute. R, would you like me to deliver some potassium IV and order an echocardiogram? So that's the recommendation. We got to treat that potassium and we got to see what that echo shows. So the nurse gets orders to administer potassium chloride 10 milliequivalents IV now. Which action should she perform first?
Read back the order.
Absolutely. So you're telling me potassium chloride 10 milliequivalents IV now. Absolutely should be the first. Everything else is right, but that should be the first thing. Make sure that you have the correct order. Potassium, or the pharmacy delivers KCl 10 milliequivalents in 100 to infuse over an hour. Before administering the medications, which actions should the nurse take? I wonder if you'll know this.
Start a new IV.
Yeah, why you want to start a new IV? That's right. Could it be because they're not compatible with those vasoactive medications? You don't want to run the potassium with the nitroprusside. You don't want to run the potassium with the nitroprusside. Okay, good. What else are you going to do?
Confirm allergies.
Even before that, should we confirm the medication to the order? So you're holding up the potassium chloride and you're going to the MAR and you're making sure that it's the right thing. Yes, confirm allergies. Yes. Why is single patient identifier wrong?
Because you need a two.
You got it. And then to determine a safe rate of administration. And what I want to tell you, this dose of potassium, this 10 and 100, is a peripheral line dose. Central lines we can run more concentrated, but this is peripheral. So if you have a peripheral line, you can't run more than 10 an hour. That's sort of a safety thing. And I'll talk about that next semester as well too. All right, next day, blood pressure stable. I don't know what that means, but I guess it is. And he's weaned off the IV medication. She reviews the intake and output below and what assessment changes are anticipated. What do you expect?
O2 sats.
Yep, because now I've pulled off that excess fluid and I can have that appropriate gas exchange. Okay, the crackles hopefully will be decreased. Stabilized, perhaps not. It should be less, you know what I mean, if I'm pulling fluid off. And then a fluid restriction is needed. Fluid is being lost, restriction. At this point, we don't know what type of, we're trying to diurese him because of the high blood pressure. We don't know if we need a fluid restriction just yet. Okay. Now let's look at number 17. He's discharged. What are you going to tell him? So tell me about furosemide. What is it?
A loop diuretic.
It's a loop diuretic.
Okay, so you guys know that, but will we tell Mr. Jones that?
No.
What are we going to tell him? What are we going to tell him?
It's a medicine to make you pee.
Okay, I like it. Fair enough. Remember, you got to teach your patients at about a 6th grade level. So that's exactly right. It's going to take that excess fluid off.
Take it in the morning.
Thank you. Why?
Because you don't want to be peeing at night while you're trying to sleep.
Yeah, I like it. So what should I be doing at home daily? Right? I got to see if that, because I got to call, right? Remember, if it's greater than 1 to 2 overnight or greater than 3 in a week. Okay, or 5 or something like that. So
Dr. Colmer,
yes.
do they ever measure their urine at home?
Not
that-
really, it's really based, I mean, it could, I mean, imagine if it's a nurse that has heart failure, I bet she would. But for the most part, we're gonna go with the daily weights.
Just the
But the
weights.
renal guys that I work for, they say that's a definite better indicator of fluid volume status, doing the daily weights. They want to know that more than the intake and output. Yes, we want to see if they have, like if they call and say, oh, I've only peed once and I'm on this diuretic, that's a problem. So really noticing any change in there, maybe amount or that kind of stuff, definitely want to know that. But I don't teach patients to measure it at home, but I guess if they wanted to, I'd be like, sure, take the urinal home, go ahead, go for it. Okay, good. Digoxin, what do you want to tell me about that?
When do we teach?
Lower your blood, your pulse.
So, all right, wait, two people are talking. So hang on, Abby. Who just said lowers?
Lowers your pulse.
Okay, so what are you going to tell them to do before taking this medication?
Check your pulse before you take it and after.
You want to make sure that they know how to take their pulse. You want to make sure that they're like not taking that medication if their pulse is 50. They got to call, right? They have got to call. Excellent. And then maybe getting lab values, particularly he's got kidney dysfunction, doesn't he, guys? So we definitely want to maybe, you know, make sure he follows up with the provider and gets those DIG levels. Give him the signs and symptoms of DIG toxicity so he's aware of that. His provider or significant other knows that maybe something's going on, the visual changes, the nausea, the vomiting, those kind of things. Abby, you had a question.
So for Lasix, wouldn't we teach them like the signs of like hypokalemia?
Oh, sure. Absolutely. And definitely, you know, maybe we need to increase it. Well, he's got some kidney dysfunction, so we got to be careful with that. But things that we could eat that have potassium in it. Absolutely. If you notice this, that, and such, or your pulse is being weird or whatever, teach them those signs and symptoms of hypokalemia and get that lab work ordered. Absolutely. Continuous previous medications. So make sure that you do that medication reconciliation of, are you on this med? Do you have this med at home? Are you taking this med? Make sure that he knows exactly what he should be going home on, and determine how they can contact the home care nurse and how they can set up for that patient to come to their house. All right, let's see. There's no end in sight, for goodness sakes. All right, let's go to 19. During discharge conversation, Mr. Jones, I grew up in a church but lost my faith during the war. I feel my days are getting closer to the end and wonder if there's something more in the afterlife. Are you a believer? So how should you begin this conversation?
I feel like maybe asking if he has a church close to his home. I don't know. I was really staring at this one for a long time.
It's a hard one. This one's hard. We'll probably get to it, but to begin the conversation, it's common when someone experiences what you've been through to feel a sense of wonder.
Yeah,
So
that was
she's
my
just
second
sort of
here.
validating. She's just sort of validating where he's kind of coming up with these feelings. And then, yes, Haley, I would say, you know, is there, and maybe it's not a church. Do you know what I mean? Maybe is there something, you know, spiritual, you know, are you a spiritual person? And is it not necessarily a church, but starting with, you know, this is common what you've been through to sort of, you know, question things. And then that'll get that conversation to open up a little bit more. That's a hard one. 20, on the way home, after the shift, she gets a call from a colleague who happens to be the neighbor. The colleague's at Mr. Joe and asked about his discharge instructions since he has some questions. Oh boy, how should the nurse respond? This is a tough one too, but think about it. Can I share with the neighbor?
No.
No. So what do we recommend?
Yeah.
Suggest Mr. Jones calls the home care nurse. Don't get caught up in that web. All right, any questions before I let you go? I talked longer than I thought I was gonna. Was this helpful?
Yes.
Okay,
Yes, very.
okay, okay. What else can I answer? Burning questions?
Just to make sure, the exam is next Thursday, right?
I hope so, because I'm not ready for it yet, but yeah, Abby, I think so. Yeah, yeah. Sarah's gonna start peripheral vascular on Tuesday, but that is not, I repeat, not on the exam. That's on your final.
So our test is on Thursday?
Yep.
Oh my God, I had the dates wrong. I'm over here.
Now we're gonna take a deep breath, right, Audra?
Woo, much better. Yes. Okay, good.
There's a method to my madness. I mean, you know. So, yes.
Except tomorrow is ATI.
For if you're a Friday person, correct. So
Yeah.
tomorrow's not new data. I mean, that is looking at all the classes that you sort of took up into this point of med surg. So it's the med surg proctored exam. So it's not going to be just my content. It's going to be all the content that you've studied up until this point. Just what you can remember, things like that. So that's tomorrow at the end of clinical. I think they're letting.
Now, if I remember correctly, we have to get on our computer and do the whole proctor thing with our badge and.
Yes, I gotta talk about Proctorio. Man, them people are tough. You think I'm tough about the event logs for your exams. Proctorio sends me pictures of you guys and goes, well, we don't know, so that's up for you to decide, but I have pictures of students. And I had one student whose computer died in the middle of it. So he texted me and said, Lorraine, I lost connectivity. So they took a picture, sent it to me, and they said, I think he's on another device. And I had to validate that he was speaking to me. I matched up our emails. He was speaking to me about how his computer shut down. They don't mess around with the protecting their tests. They're like legit. It's like that for boards too.
So I've got a quick question for you, just so you know. Should I email you that I use, my laptop is hooked up to a larger monitor because my screen is broke. When I hook it up to the larger monitor, it shows. I mean, I've never had a problem before and I've been using it, but I just want to make sure you're aware that it's a big monitor in front of me. So I'm not looking at my computer, I'll be looking at the monitor.
I got you. I hear you. Okay. Yeah, and they may send me and say she's on two things, and I'll be like, yeah, I know, I already talked to her about it. So I'm the one that makes the final decision of the pictures. And boy, have I gotten some. So just be careful what you do, because there really is like someone that does pay attention to that.
It's like a telesitter.
It is, right? You're climbing out of bed. You're like, hey, get out of here.
You're like, don't move. She just blinked the wrong way.